Okay, I would like to welcome you all to another exciting episode of the Nailed It Orthopedic Podcast. We have another great one in store for you guys today. We have with us Dr. Salazar. How you doing today, sir?
I'm doing great. Thanks so much for the invitation. I'm really looking forward to a lively discussion.
Absolutely. Even our quick conversation off air, I mean, you got us really hyped up about this talk. I mean, within 5 minutes, so I'm pretty sure our listeners are going to really love it. Um, but we always start off before we get too far into the topic. We just ask some questions just to kind of get to know our guests a little bit more, so that our listeners can kind of get a vibe for who you are and what you're about. Um, so, what made you choose your specialty that you decided to go into as far as upper extremity?
So I would say it started first and foremost with mentorship. I had a lot of great mentors in the shoulder and elbow community, and throughout my training, I really felt myself gravitating towards that topic. I would gravitate towards a shoulder and elbow journal articles to read for pleasure. When studying for in training as a trainee, I would gravitate to question banks in either sports and shoulder and elbow. And for me, anatomically, it made a lot of sense. It didn't feel like a chore to hone my craft, and I really enjoyed the surgeries that came with it and the gamut that you can do in our subspecialty. Everything from fracture work to arthroplasty work to arthroscopy work to tendon transfers to peripheral and brachial plexus nerve type of work. And so it really intrigued me that you could have a very diverse practice, both in the type of cases and patients that you saw and age, but at the same time became an expert in an area of the body and could really be a referral base for the community that you support.
And yeah, I've always thought that around the elbow and I don't know, around the shoulder as well, but definitely the elbow, it just seemed like a lot of people are a little bit more hesitant to operate around that area. And they kind of prefer to have like you say, a specialist deal with this. So like you said, I bet that is a very good field to go to as far as getting a lot of patients referred over to you for dealing with different pathology around the elbow and shoulder.
Yeah, in my practice, I see obviously a lot of patients that are referred by primary care doctors and self referrals, but I also have a large percentage of patients that are referred by other orthopedic surgeons to take care of complex problems about the shoulder and elbow, which are very challenging and provide excellent training opportunities for our residents and our fellow.
I think that's great, and I think the way that you explained your specialty and the wide diverse array of things that you can do, I think that's definitely attractive to that specialty. And anybody listening, they may this may be something that wakes them up as to something that they may want to do. But moving on to the next question that I have for you, is there any advice that you would give yourself at age 25, or when you first started off doing your training, looking back at it now, is there anything that you would go back and give yourself, or if you know somebody else is 25, advice that you would give them?
Yeah, I mean, I think the best advice I would have is to really have an introspective understanding of yourself. And what I mean by that is have a working knowledge of what are your personal goals, what are your professional goals, what does your ideal practice look like? Because I think oftentimes people will start to get a little bit of tunnel vision. I want to live in this town, or I want to join this practice. And 4 or 5 years ago from now, they may have this need. So maybe I should go into that subspecialty so that I can join that practice. And really, I tell people you should know what you want and really work from that moving forward. And the doors that should open themselves will open themselves. And so the best advice I have is don't make up your mind too early in your training. because you may be very surprised to what you gravitate to, or what comes naturally to you, or what you want to do for a career. Orthopedics is extremely rewarding, and we get to wake up and take care of patients and render world-class operative and non-operative care, which I really consider a privilege. And so it's really important that we make decisions that give us the most reward professionally, but also personally as we move forward in our life. So my best advice would be, have a good understanding of who you are, what are your strengths, what are your weaknesses, what are the things you can work on, and what are your goals, and then craft a strategy to get that ideal practice.
I think those are all excellent points, and that's maybe something I may go back and rewind this past minute and listen to that again and really take that to heart. And when you're trying to think of what you want to do, especially with your life, because just like you said, this is a lifelong thing, and orthopedics is a great specialty. So I think that was another great answer.
Yeah. And it's
And
actually something to kind of live by even outside of, orthopedics. So yeah, absolutely a great response. But to end it on, last question, to end it on something orthopedic based, what you think is your favorite case that you would like to do?
Yeah, it's a running joke at our residency, because I often say this is my favorite case to do, and the problem is it's a myriad of different cases. But the topic that we picked tonight is probably one of my favorites. Total shoulder arthroplasty is, in my opinion, a very cerebral procedure. And philosophically, I look at it not as a hardware surgery, but more of a soft tissue surgery where we implant hardware, where the soft tissue balancing and the preoperative templating and the preoperative planning and the intraoperative plan and troubleshooting is exceptionally important for the patient to have a good outcome and maximize the function that that person's going to have. And I don't think that's true of all surgeries. There are other surgeries that I do that are much more forgiving. I would contrast it to the reverse shoulder arthroplasty, which, in my opinion, is more of a hardware surgery. Their soft tissue balancing is much less important. We're bypassing the function of the rotator cuff. We're changing the biomechanics of the shoulder, and it's a much different procedure. So I enjoy really all surgeries that I do. I really feel that shoulder and elbow for me was not a job or a vocation or even a profession, but for me was a calling. And I feel very privileged to do it. So, I like the challenges of revision arthroplasty. I like the challenges of nerve work and tendon transfers. And the reality is, I like connecting with my patients and providing them a service that gets them back to their either baseline of health or improves their function. So, but to answer your question, total shoulder arthroplasty or anatomic shoulder arthroplasty is very high on the list of surgeries that I really enjoy performing.
excellent. I think that was a great explanation. And speaking of total shoulder arthroplasty being the best thing that you love to things that you love to enjoy doing, um, I wanted to, who gets a total shoulder arthroplasty? What patients? I mean, we're going to move into the talk. So, what patients get total shoulders? Like, what are the indications for it, and what people should not be getting total shoulder arthroplasties done?
Yeah, so we'll first start with people that are indicated for shoulder arthroplasty. Typically, I would say it's the patient that has lifestyle limiting pain secondary to degenerative joint disease or an arthropathy of the glenohumeral joint. And classically, that's osteoarthritis, but also rheumatoid arthritis, psoriatic arthritis, and many of the other arthropathies are very appropriate. And I always tell patients in my discussion with them, the person that decides if and when a patient should have an anatomic shoulder arthroplasty is the patient. I pride myself on not treating x-rays, but treating people. And so sometimes you look at an x-ray and say, wow, That's end stage arthritis. They've obliterated the joint space. They have large marginal osteophytosis. They have a lot of subchondral cysts. There's a lot of wear. And you go in and meet and discuss with the patient. They say, yeah, I have some aches and pains, but I'm retired. I'm able to do most of the things. I can sleep on my shoulder. I can reach for things. It bothers me. But either oral medication or an injection really manages my symptoms. And other times you look at an x-ray and you say, yeah, this patient has joint space narrowing and marginal osteophytes, but it's not the worst radiograph I've ever seen. And then you go in the room and they really have debilitating stiffness, debilitating pain. They can't enjoy their hobbies. They can't work. They can't play with their kids or grandkids. And those people that have lifestyle limiting pain that have exhausted non-operative treatment, I think are an excellent patient population that can do very well with shoulder arthroplasty. Obviously, patients with open wounds, active infections, people with acute fractures, um, people that have ongoing bone tumors or septic arthrosis would not be indicated for at least until they cleared those pathologies, shoulder arthroplasty.
Now, anytime typically when you read and, you look upon everything, and when they talk about total shoulders, they'll say that they have to have an intact rotator cuff.
Yeah.
Why is that important with total shoulder arthroplasty?
So, total shoulder arthroplasty, or probably, in my opinion, more accurately, anatomic shoulder arthroplasty, requires the soft tissue of the shoulder girdle to balance the implant. It's an anatomic prosthesis, and the anatomy around the shoulder has a lot of range of motion and relies very heavily on the labrum, compression concavity, the rotator cuff, and deltoid to balance the shoulder and make the shoulder stable. And so, if the rotator cuff is not functioning or it is torn and unable to function, achieving a balancing of the soft tissues is improbable and impossible. And very predictably, those patients don't do well. Now, that does not mean that people that have rotator cuff tears cannot have shoulder arthroplasty, or that people that have previously had rotator cuff repairs and have gone on or concomitantly had arthrosis of the glenohumeral joint aren't eligible. And we, on rare occasion, will actually do a rotator cuff repair at the same setting that we do anatomic shoulder arthroplasty. Now, this should be a repairable rotator cuff, and there's different things, tissue quality, atrophy, fatty infiltration, the size of the tear that would all play into that. But a small to medium-sized rotator cuff tear in someone that has a good likelihood of healing that tear is eligible to have a rotator cuff repair done at the same time as a total shoulder. It does change the postoperative rehabilitation in my practice, but certainly it's something that I discuss as an option with people that have small to medium-sized repairable rotator cuffs.
So I guess the key word is irreparable rotator cuff tears. Just like you said, there's some rotator cuffs where you can just repair it, intraoperatively. But if it's something that cannot be repaired, then that kind of leads to your soft tissue balancing. Just like you previously said, this is kind of a soft tissue balancing procedure with some implants.
That's correct. And to expand on that a little bit, just because we can technically repair something doesn't mean it has a high likelihood of healing. And so I think that's where really taking into consideration and really scrutinizing, especially advanced imaging, to look at the muscle bellies of the rotator cuff, especially the subscapularis and infraspinatus, that we really need for the coupling mechanics of the shoulder, and seeing, is there fatty infiltration? Is there atrophy? Does it involve the anterior or the posterior cable? Is there retraction? How chronic it is? I think all of those things play a very important role in decision making when offering total shoulder arthroplasty.
Perfect. And yeah, that is like a very high yield topic, or a concept to understand about the need for a working rotator cuff. So I'm glad that you broke that down as well as you did. But as you mentioned, as far as imaging, when you're considering doing this type of surgery, a total shoulder for a patient, what type of imaging are you getting for these patients?
So most patients will come to me and will typically have an MRI already. Um, and that gives very, very good data. But the one unfortunate thing right now with the implant systems that I use is the preoperative templating software requires a CT scan. So I still, on the overwhelming majority of patients that I'm planning for a total shoulder arthroplasty, obtain a CT scan, even if they've already had an MRI. And those two advanced imaging modalities do give me different information. The MRI gives me very good information about the rotator cuff. Now, if a patient doesn't have an MRI, my advanced imaging modality of choice is a CT scan. And I believe that on the soft tissue windows of a CT scan, especially if you're used to scrutinizing and looking, you can very accurately gauge fatty infiltration and atrophy of the rotator cuff. So I will often tell patients that the reason we're getting a CT scan is, yes, to look at the bony anatomy, to look for acquired retroversion or asymmetric wear of the glenoid, and to look at glenoid bone stock and to measure humeral retroversion. But also it allows us to look at the soft tissue. I can see the superior rotator cuff and the anterior rotator cuff very accurately on a CT scan. And if there's a question about that, oftentimes I'll order a CT arthrogram, and that will very accurately allow us to look at that. I typically would use a CT arthrogram in patients that have a pacemaker, loose metal, strap metal, things of that nature that can't have MRIs. But my advanced imaging modality of choice for preoperative templating is a CT scan.
Awesome,
Now,
awesome. I'm glad that you brought that up. I was actually just recently teaching young Cody about that. Hey, you can actually see the rotator cuff pretty well on a CT if you look for it. And so I'm glad that you broke that down for him. He's still kind of getting those basic concepts there.
this guy.
Yeah, the classic Goutelier
Yeah,
classification is validated on this on the CT, and I
right.
think some people forget that that was the original description.
Yep. I think later on they got a little bit more fancy and added in some changed some things so that it could be done on MRI as well. But yeah,
That's right.
originally it was on the CT. So, is there, what about just basic x-rays? Is there, what x-rays are you getting as well for these patients? And while we're on that, is there any classification systems that you use when you're looking at that or anything like that?
Absolutely. So my classic series is 4 views. It would be a AP view, a Gracie view, an axillary, and then a transcap Y. I don't typically get a Bernagau. I know a lot of my colleagues, especially those that trained in Europe, specifically France or Switzerland, like that view. I think it's a great view. It's just not something that our X-ray technicians are very facile with. And to be honest, I believe that the axillary views that we get are accurate at showing what I'm looking for. So the important thing about the series that I get is in my Gracie view, the patient is actively abducting or firing their deltoid to about 30 degrees. And what that allows me to see is it accentuates proximal migration. So in certain patients, you may say, well, on the X-ray, they look very centered. There's no proximal migration. The acromial interval looked normal. And then you get the MRI, and all of a sudden, you see this huge amount of proximal migration. And the reason for that is that typically X-rays are obtained in the upright position, and the weight of the arm through gravity does not allow the proximal migration. When the patient is supine for the MRI, gravity is taken out of that, and that accentuates that. So to actually pick up on that before I have advanced imaging, I ask the patient to fire their deltoid, which takes the weight of the arm out of it and actually accentuates that. And that's best seen on the Gracie by noticing that the interval at the top of the glenoid compared to the bottom of the glenoid, so superior glenoid, that interval between the humeral head and the glenoid is a different measurement than it is inferiorly. And so in a concentrically reduced shoulder without wear, those two measurements should be the same. The other thing that I often becomes a trick question with trainees is when you're getting an AP X-ray, which really should be perpendicular to your AC joint, and it looks like a Gracie, what should you be thinking of? And the answer to that is you should be thinking about the glenoid being retroverted and substantially retroverted, that the glenoid and the AC joint are in the same plane, so that an AP looks like a Gracie. So that's one little tip that I would have when you're looking at X-rays. If you're looking at an AP and you can see right down the joint line of the glenohumeral joint, you have to have a very high index of suspicion that that person has a great deal of retroversion of the glenoid, either acquired or congenital.
And since we're touching about the glenoid, are there any classification systems that you use, for
Yeah, I think
preoperative planning or?
Yeah, not so much for preoperative planning. For communication, for research purposes, Samuelson Prieto, which measures the size of the inferior osteophyte, the marginal osteophyte, that is the classic billy goat's beard that's described radiographically. And that depends on the measurement of that, less than 3 millimeters, 3 millimeters to 6 millimeters, greater than 6 millimeters. And then there's all kinds of descriptive classifications of wear patterns on the glenoid. The most commonly used and the one that we talk about is Gilles Walch's classification, where he classified asymmetric wear, which would be your B glenoids, and then centered wear, which would be your A-type glenoids, which is depicted here diagrammatically. And there have been some additions to this. There's now a B3 and D, but those all have to do with severe retroversion. And we can talk a little bit about how important that is in not only intraoperative, but preoperatively thinking about what your implant options and choices are when faced with a patient that has a great deal of retroversion. The one I would say that most shoulder and elbow surgeons have the most consternation about is the B2 glenoid. And that's a glenoid that has biconcavity, where there's a paleo glenoid in the front, which is the original glenoid, and then a neoglenoid, which is the new glenoid, where the humeral head wears asymmetrically and they get acquired retroversion, and then there's a ridge between the two. And that's typically associated or concomitantly patients will have posterior subluxation of the humeral head, which is typically judged on a percentage. So a centered head is 50%. And so if you say a patient on their CT scan or their MRI demonstrates a 80% posterior subluxation, that's actually 30% from the center line.
Okay. And, it seems like we're hinting a lot at how important the glenoid is when considering arthroplasty surgery for patients of for their shoulder. Can we go over some of the relevant anatomy for the glenoid?
Yeah, absolutely. I mean, the reason that we spend so much time thinking and talking and discussing about the glenoid side for anatomic shoulder arthroplasty is that any chain is only as strong as its weakest link, and typically the complications have been on the glenoid side. And when we think of it, aseptic loosening is something that we worry about. But there's a lot of important anatomic things to note. So the long head of the biceps inserts on the superior pole of the glenoid and provides a very nice landmark, not for perfect 12 o'clock, but it's slightly posterior to that. And so I'll often intraoperatively use that as a reference line for my superior to inferior axis, where that biceps inserts. Inferiorly, you actually have the long head of the triceps, which we often will recess, and especially during reverse arthroplasty, will recess so that we can get inferiorly. Typically, the glenoid has a pear shape. We all have classically learned the inverted pear shape, which is associated with attritional bone loss from chronic or recurrent anterior-inferior instability about the shoulder. And patients that have history of instability and go on to have post-stabilization arthritis, or go on to have arthritis because they remain unstable, pose a challenge because they morphologically have a different shaped glenoid, and we worry about bony support for any implant that you may want to put in. And then the base of the coracoid is a very good landmark intraoperatively. And then obviously the anterior and posterior to the vault, the cortex can be used for referencing, and some referencing guides will actually have a small attachment that looks like a curved finger that can actually rest on the anterior glenoid as a landmark to use for center axis. And then obviously you have some parameters that are written out here. Mean sizing, it can be helpful, but a very large male glenoid that has significant medialization and wear can be very large. And then on the other side of the spectrum, you have a very petite woman that does not have a great deal of medialization, may have a very small glenoid. But I think it is important to note that the average person is slightly retroverted, depending on what you read, anywhere between 1 to 7 degrees of retroversion. I classically kind of cite to my trainees about 4 degrees of retroversion, but different studies. But the basic understanding here is that the human body has a slightly retroverted glenoid.
Now, what are some things that we need to consider regarding glenoid, or I guess how do we address certain different type of glenoids, right? Like
Sure.
how do we address a glenoid that's retroverted? Like what does that do for our planning for patients undergoing total soldiers versus if they have a big defect or like a large Bankart lesion per se, or what are some things that, like, how do we manage those?
Yeah, absolutely. So these are the reasons that preoperative planning and templating are so very critical and important, because they get you to start thinking and troubleshooting and coming up with contingency plans before you ever get to the operating room. I think one of the fallacies is to get into the operating room and run into some of these hurdles and have to think on the fly. And I think we have a lot less clarity at that time, that if we think about what are the things that are going to be challenging, we can plan for that. And so in my practice, especially, as I alluded to, the B2 glenoid is something that I talk about, worry about, teach about all the time. And a great deal of that has to do with the fact that you see that morphology in large men, men that have been weightlifters. And so they have a big deltoid. They have a lot of muscle bulk. And so visualization of the glenoid is going to be challenging. I personally use something called a deltoid or a Brown retractor that wraps around the greater tuberosity and helps get me visualization in the beginning. And then when I'm working on the glenoid, classically, a lot of people will use a Fukuda retractor, and I find this to be a little bit cumbersome. So I actually use 2 Bankart retractors in the back and a broad single Bankart retractor in the front, and I work around that. But the Bankart retractors are somewhat malleable, but you'll find in a very large man with a large deltoid, that's very retroverted, that you can't get your hand posterior enough to be able to drill your central axis pin in line with the axis of the scapula. And so um, that may be an instance where you want to send away for a custom guide. Many of the implant companies have programs where you upload the CT scan, and then you can build either custom implants or custom guides that help you set your central axis pin in challenging cases, so that where you lose bony references or where you're going to have difficulty visualizing or getting the correct vector to put your instruments in, that you have an implant that can snap onto known landmarks. And so when I know I have a retroverted glenoid that's, say, 25, 30 degrees of retroversion, and I've decided that I'm going to either do a full wedge augment, bone grafting, hemi-wedge augment, step augment, inlay glenoid, any one of those things are in your armamentarium. But the key to that is you have to be able to implant those. So you have to get visualization. So what I always say is never sacrifice glenoid exposure, because that's when you won't be able to put the implant where you want to put it or where you preoperatively templated it. So the two tenets of shoulder arthroplasty surgery, in my opinion, are axillary nerve management and glenoid exposure. And if you can master those, you can be a very elegant and sophisticated shoulder and elbow surgeon and really have a solution to all complex problems. Now, the other thing that you've alluded here is glenoid bone stock. In the past, we say, well, if you don't have enough glenoid bone stock to accept a glenoid component or a reverse shoulder arthroplasty component, you would classically put in a hemi-arthroplasty or graft and come back and do a staged. But there are now custom implants that you can upload CT scans that do a reconstruction of the vault, and actually engineers find enough bone stock to put secure fixation in, and it's a custom implant. Now, those are obviously rare cases that require a lot of planning, and they require a lot of time because the company has to create a custom implant. So that's not a surgery you can offer in a week or two. That's something you have to plan sometimes for several months for. But the days of, well, you don't have enough bone stock to implant anything, we have advanced past that a little bit. And that's not to say that hemiarthroplasty might not still be the best option for some of these people as a good pain relieving surgery. But the drawback has always been they may get good pain relief, but their function may be quite variable because of the biomechanics of the shoulder being so altered, especially with that much medialization.
All right. So just to recap, so some of the high points and things that you were saying were that, patients, that have a retroverted glenoid, or even those B2s, some of the big things are going to be exposure and visualization of the entire glenoid. And then you also touched on, axillary nerve management being another essential part to having a good outcome, or at least a good case.
So to expand on that and hammer that point home, because I see what you're getting at, which is what are the strategies that we have for dealing with a retroverted glenoid? And so in my opinion, the strategies that are out there, one is you can do kind of play it as it lies. So you can say, well, the patient has been living with a posteriorly subluxed humeral head and a retroverted glenoid. And really what I want to do is resurface the joint and allow the anatomy to stay where it is, because the chances that I can appropriately rebalance the soft tissue aren't great. And the chances that it wants to continue to posteriorly luxate after I do my arthroplasty are high. And that's the play it as it lies. So you can do an inlay glenoid, and there's several out on the market. And that's basically you put a glenoid into the vault, but doesn't cover the face of the glenoid. And then you could do a humeral head. You could do a resurfacing implant, and basically you would allow that patient to stay posteriorly luxated and say, we're relieving your pain with this, and we're going to allow your anatomy be where it is. Okay, so that's one strategy. The other strategy that especially is used often when the amount of retroversion is not substantial, and say between 15 and maybe less than 20 or 23 degrees or so, would be reaming down the high side. So you say, well, I will correct or partially correct the retroversion by putting my axis pin in a manner that I preferentially ream the anterior cortex to the posterior cortex. And I would say that's a very good strategy. And for the most part, people would say, yeah, I'm not trying to get back to the 1 degree. I'm trying to get back to about 5 to 10 degrees of retroversion, and I'm willing to accept that. So once you get past that, then you say, well, okay, now there's 30 degrees of retroversion. What are my options? Well, your options are you could go to a reverse. Your options are you could use a bone graft, a structural cortical bone, and there's many places that you could get that. And you would secure that and then correct the retroversion and put a normal implant on that. Or you could have implants available that are designed to have a posterior augment, and that there's multiple versions of that, but we have a hemi wedge out there. There's wedge augments out there, full wedge augments. There's step augments. And so all of those things give you a myriad of tools when you're dealing with this. So for me personally, it depends on a lot on how much retroversion, how much posterior luxation, and what are my goals for this patient. And out of all those surgeries that I've mentioned, I've done all of them. And so I think it's important that you don't treat every patient with retroversion with the same solution. Some patients are ideally suited for one or other of those myriad of choices that I mentioned. Now, the one thing I'll also hint on and touch on briefly is the most challenging patient in my practice is the young person that has severe glenohumeral arthrosis. So think about the 35-year-old person that has end-stage glenohumeral arthrosis. That is the person we've not come up with a reliable, predictable surgical solution for. And in that patient, we've done hemiarthroplasty. We've done Dr. Matson's technique of ream and run out of the University of Washington. And what that is basically hemiarthroplasty, where you do glenoid preparation minus actually implanting a glenoid. So you actually ream the glenoid. You do the same preparation with the labral and soft tissue releases of the inferior and middle glenohumeral ligaments that you would normally do, but you don't implant a glenoid. And then you have hemi caps, resurfacing, inlay glenoids. There's a lot of historical research that has gone into soft tissue interposition arthroplasty, which unfortunately the literature has not borne out to be a good or lasting option, unfortunately. And we've used a myriad of different graft options, none of which have performed very superiorly. And so I would say the most difficult patient for me for anatomic shoulder arthroplasty is the very young patient because of the wear that we worry about that could occur while they're still a relatively young age.
Awesome. And you actually did go through a lot of the different implants that you may use for different situations, but could we just go over some of the basic implants that you should keep in mind, and that may even be high yield on some of the board style questions and things like that when considering the glenoid portion of this procedure?
Yeah. So, typically the classic anatomic shoulder arthroplasty is going to be a stemmed humeral component mated with a metal humeral head that has either um, eccentric options or is completely concentric. And that all depends on what system you're using and what generation of the system. We had Dr. Neer had his monoblock non-proprietary implants that were available. And since that design, we've continued to engineer more and more modularity into that so that we can more either appropriately or accurately mimic individual patients' anatomy. But and then mated with that classically is an all poly cemented glenoid, and there have been many variations on this: metal backed glenoid, anchor peg press fit glenoids, several of which are depicted here in the images on your slide. And so the image that you have here is probably what I use the most, which is an anchor peg glenoid, and that's a hybrid where either the central or the peripheral, the system I use, it's the central peg, is a press fit, and different people will debate differently whether there's ingrowth potential, but I think the one thing that's not debated is that at time zero, there is a press fit component that either the central or the peripheral pegs is held tightly or snugly into place. And then the peripheral or the central peg, depending on what system you're using, is cemented in so that you're using kind of a hybrid. I personally have not implanted a lot of keels based on the long-term data of keels versus pegs, but there are keel designs that are still out there. And those from time to time are appropriate when you have a contained vault bone loss. A keeled glenoid may be a good option. But we have published recently a paper where we looked at anchor peg glenoids and looked at the press fit at time zero and investigated whether the cement in the other pegs has enough strength to actually lift or push the glenoid off as the cement expands, getting to the question of, do you have to hold pressurization on the glenoid until the cement cures? And what we found in a cadaveric study is that the anchor peg press fit is strong enough that once you implant the glenoid, you no longer have to let the cement cure. You can move on to the humeral side or finish your case, depending on the order you do things, without having to wait that 8 to 14 minutes to allow the cement to cure. So big picture, I would still say that the standard of care in this country and the most popular total shoulder arthroplasty being put in is an all poly cemented glenoid mated with a metal stem and metal humeral head. That being said, I myself in my practice and many of my colleagues have done many stemless implants, and we can talk a little bit about the European experience, which has been going on much longer. We now have, I believe it's up to 4 stemless implants on the market here in the United States. And there are varying pros and cons to that.
No, that was excellent. And I think I even saw some test questions that asked about keels versus pegs in the glenoid component.
If
kind of
you see a question about that, I would choose peg over keel.
Yep.
There are very few scenarios under which the keel would outperform a peg.
Yep, and that's exactly what the answer was. I think that was excellent. Is there anything else as far as the glenoid component that you think is important to know before we just quickly move on to the humeral sided component?
One of your slides showed a picture of several of the shapes of the glenoid, a more oval shape, a more pear shape. And the reality is we don't have good level 1 evidence that guides us on which one of these shapes acts superior. And I would say in my own practice, shape C and shape B would be the two most common that I implant. And I use different companies for different surgeries or when I need different solutions for patients. And so I use both B and C, and in my own practice, I've not seen them perform differently. But we'll need long-term data to know, is a pear-shaped glenoid, which is slightly more anatomic appearing, clinically more relevant than the more classic oval shape.
And since we're just on that, can you quickly talk about the congruity? Does conforming versus non-conforming, is there any difference between the two?
Yeah, so the native shoulder, if you think of the shape of the glenoid, think about even when you're doing shoulder arthroscopy, the glenoid is fairly flat, meaning it has a very large radius of curvature, and the humeral head is much more curved. It has a smaller radius of curvature. And so the original shoulder designs harken back to what we thought a little bit more about knees, which is a much more congruent or conforming, meaning the radius of curvature of the glenoid and the radius of curvature of the humeral head matched. And what we found over time is that that did not mimic what happens in the shoulder. In the shoulder, there is both a pivot, a roll, and a slide. And so the exact range of the appropriate radius of curvature is debated in different literature. We'll quote different things, but I think most people will agree that the range is probably between 4 millimeters and up to 10 millimeters. And certainly the smaller number would mean you're more congruent. And I would say most people would say you don't want to be more congruent than about 3.5. And then on the other end, you also don't want too much incongruity because that can lead to luxation. And so different implant companies have different combinations. So the combination of radius of curvature mismatch between the glenoid and the humerus changes from what size glenoid you select and what size humeral head. And so, for instance, with the Zimmer Biomet system, you can pair them, or it's advised that you pair between 3.5 and 8 in their system. In Tornier, it's much more variable. You can go all the way from 1.4 millimeters to 24.8 millimeters. With Medacta, it's between 2 and 10. So there does seem to be this range that seems to be the ideal range. In my opinion, it's somewhere between 4 and 8 millimeters. But what we do understand is if that number is too small, meaning the radius of curvature does not have enough mismatch, then the shoulder won't behave like a native shoulder does. And there is some research that the number that most accurately reproduces what the native shoulder does in a non-arthritic shoulder is between 3.5 and 4 millimeters.
Okay. And yes, sir, all those are high yield points that I'm hoping everyone is grabbing from all the pearls you're dropping for us. On just before we get too far to the end here, what is there any other high yield topics that we probably should discuss on the as far as the humeral implants?
Well, the one topic we haven't touched on, which is something that I spend a great deal thinking about and worrying about, is subscapularis management. And so the three techniques classically, and now a fourth technique, which would be a subscap sparing technique. But classically, the three techniques to deal with the subscapularis are a peel, a tenotomy, and a lesser tuberosity osteotomy. And there's pros and cons, and people advocate for all of those. To be honest, there's good data that people can support any one of those three decisions. I personally, in the overwhelming majority of cases, and now this is changing the more I do stemless implants, but classically, I always did lesser tuberosity osteotomies. Now, Some people would say, well, peels and tenotomies do just as well. And I don't disagree with that. But my reasoning is one that's fairly practical, which is I can't see a peel and I can't see a tenotomy failure on x-ray. And what I get postoperatively are x-rays and serial x-rays. So in order to fully confirm that there's been failure of the subscapularis on x-ray, you need to see luxation or frank dislocation out the front of the shoulder. However, with an LTO, if I see interval displacement either at the 2-week or the 6-week x-ray, I know that I've lost secure fixation and I can intervene before the shoulder luxates forward, because the truth of the matter is we do not have a good surgical solution for total shoulder arthroplasties that do not have a working subscapularis or an intact subscapularis. The native shoulder, we've done lat tendon transfer, pec tendon transfer, partial pec tendon transfer, but in J.P. Warner and Bassam El Hassan's work at Mass General, the single subset population that did very poorly with tendon transfers for subscapularis insufficiency were people with anatomic shoulders. So that is a problem we don't have a great solution for. So anytime in orthopedics, when we don't have a solution, I want to avoid that problem. And
Right.
one of my ways to avoid that problem is to do an LTO so I can intervene early. Now, Serena Nandari and the group at Thomas Jefferson at Rothman just looked at subscap repairs in shoulder arthroplasty. And so I would urge your readers to look at that in the latest Journal of Shoulder and Elbow Surgery. So there's a lot of work going into subscap management, and some people will fix over a small plate. We saw an x-ray where that occurred. And George Athwal has some very good data where he compared LTO to peel. And I would say my one caution or caveat to saying, concluding from his research that a peel does as well as an LTO is not everyone is doing a peel with the sophisticated technique that Dr. Athwal has advocated and used on his patients. So you have to make sure you're comparing apples to apples. But I think you'll get a lot of questions about subscapularis management, and that's kind of a high yield topic when you're talking about anatomic shoulder arthroplasty.
And I think you just mentioned it, but things that you would do to intervene if you did that less tuberosity osteotomy and you see they come to your clinic in a couple of weeks and you notice that that it may be kind of spreading apart, is your intervention, you may possibly go back and plate it, or put some screws, or what is your
Yeah.
intervention at that time?
Yep. So typically I would go back in and I would fix it down with bone anchors, because the original repair that I do, the sutures go around the stem, or what we would call the nucleus of a stemless implant. So they're actually anchored into the proximal humerus by the shoulder implant. And so obviously I do not want to remove the shoulder humeral implant to do my repair. So at that point, what I would do is I would put suture fixation into the subscapularis over the top of my LTO, and then laterally put rows of anchors, much like a double row rotator cuff, so that I have anchors medially, anchors laterally, and then suture bridge over the top of that wafer of bone.
I think that's all. I think that was great, and and I'm glad that you brought up the management of the subscap too, because that's a big, that is a big part of total shoulders, and I actually see a lot of questions on it as well. And just like you said, you may actually see that in practice, and you definitely want to avoid something that you don't have a good fix for. Just like you said, you can't really uh, do as many of the tendon transfers in total shoulder patients as you can in non-total shoulder patients.
Mhm.
Um, and just moving on, any high points that you like to quickly touch on as far as regarding the humeral side of things,
Yeah, I would
regarding
say
total shoulders?
the one the one classic parameter that we think about the most and technically want to ensure is correct is the proximal humeral retroversion, and it's very variable in the in our population. As you have written here, 25 to 45 degrees, that's a 20-degree difference. And so I will typically put people in the amount of retroversion that is their native retroversion. And sometimes that's 45 degrees, sometimes that's 20 degrees. So I will typically try and recreate their a retroversion. Some people will just use a cutting guide that they set their retroversion. But what I would say is whatever implant system that you use, be very facile with accurately measuring the amount of retroversion. And the amount of retroversion that we're looking to put different implant systems, for instance, contrasting in a reverse shoulder arthroplasty, I'm usually putting people in between 0 and 20, shooting for about 10 degrees of retroversion. And for an anatomic shoulder, I'm probably more on the order of between 35 and 40 degrees. And so you want to know how the implant system you use accurately shows that. And there are guide rods, and some implant systems will use 2 guide rods, 1 guide rod, but just be very facile with the way you measure, because you don't want to implant your humeral stem in too much anaversion. Okay. Now you may still be retroverted, but you may only be 5 degrees retroverted when you actually wanted to put them in 45 degrees of retroversion, and that can have consequences on the clinical performance of a shoulder. So for me, the humeral head cut is very important, both for inclination and for version. And I want to be very accurate with that. And so the classic thing that always comes up with is that you have to take off the marginal osteophytes that are formed on the humerus to accurately understand where the native articular margin is to put your humeral cut. Because if you make your cut before you take them off, the tendency is to go into too much varus, and that has its own sets of consequences.
Okay, perfect. And I think I feel like I was going to ask about complications, but I actually think you did a great job kind of going through them throughout the talk. We talked about, you have to worry about glenoid loosening. We talked about you have to worry about, your subscapularis repair. Other than that, I know infection is always something you have to look out for, and in shoulder, P acnes, which is actually I think C acnes now,
Yeah.
is actually pretty high yield for shoulder surgery, and it comes up late. So for everyone listening, don't forget that it comes up much later than some of the other bacteria that you get on culture. But before we finish, I did just want to ask this, and we probably could wrap it up after that. As far as post-op in rehab, what can these patients not do? How soon are you letting them, kind of range their shoulder and things like that? Just kind of what is your usual post-operative course?
Yeah, so I let them range immediately. So they're allowed forward elevation actively in the plane of the scapula as much as they want post-op day 2 or 3. So I typically use either a long-acting interscaling block or an indwelling interscaling catheter that works for between 48 and 72 hours. So once they get back protective sensation and motor function, they come out of the sling and they're allowed adducted external rotation actively, and they're allowed forward elevation in the plane of the scapula. What they're restricted from is reaching behind the back, so internal rotation behind the back, lifting more than 3 to 5 pounds, or weight bearing. And most commonly that would be getting up out of a chair or opening a heavy door. And the reason they have those restrictions for 12 weeks is for the subscapularis protection. So I want the LTO to heal. And so I protect them from those movements. And very, very infrequently, but after 6 weeks, you could still see some interval displacement if you don't have full bony healing. So I do restrict them until 12 weeks, until I have a radiograph that shows that the LTO has bony healing or has no interval displacement. And then we take those restrictions away. And after that, really, it's progressive strengthening. And I tell them that I don't want them doing upper body repetitive weightlifting. So I don't really want a total shoulder go back to bench pressing. But I'm under no illusion that some of my active younger patients that are Secret Service agents, SWAT team members, Chicago police officers, active duty military, that they don't go back to that very active lifestyle, especially when their shoulder feels so much better. And so I have patients in all of those professions that I just mentioned that have shoulder replacements. And I have a SWAT officer on the Chicago police that has bilateral shoulder arthroplasties that is back to doing a very rigorous and demanding job.
Man, wow, that's wild, and that's crazy. You always like to think the effects that orthopedics and really taking care of patients can have, and how you can get patients back to living, their life, or at least to the activity level that they want to. But Dr. Salazar, this has been a great podcast episode. I think it's been a great talk. I know I learned a bunch already about total shoulder arthroplasty. I know Jay's been taking notes the whole time. He never heard of half this stuff before.
All right, well, now the secret is out. That's fine.
We really appreciate you coming on the podcast and talking.
Well, I appreciate you guys. I think what you're doing here is really important. And it's really a novel way of delivering didactic education to a very captive and interesting audience. I'll just put a plug for my program. I'm at Loyola University here in Chicago. So for anyone that's interested in ever coming to see some interesting or complex cases, spending time with us doing shoulder and elbow, or coming to work with us, being partners or being trained by us, either in upper extremity fellowship or coming to be a resident with us, I would just ask you to go online to our website, check us out, and contact us. More than happy to chat about our program, our experiences at our program. And as a hometown Chicago guy, I'm very biased that I live in the greatest city in the world, at least in the summertime. So we're always happy to have people come visit us, check out the program, and see the great things that we're doing for our patients at Loyola.
Perfect. And to everyone listening, thank you all, and see you next week.